The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC. And for patients with mitral valve surgery, the MACE procedure is very effective in treating atrial fibrillation. But exactly which MACE procedure should be done, how extensive, remains an area of debate. And we have a paper in press that addresses that very issue. We have with me Dr. Francesco Onorati, and he's on the staff of the University of Verona in cardiac surgery and has done a study looking specifically at the MACE procedure in patients undergoing mitral valve surgery. Tell us a little bit about your study.
We have looked at our whole experience during the last 5 years aimed at addressing the AF surgery during a concomitant cardiac surgery. We analyzed retrospectively our whole experience, and in particular we are looking at the electrophysiological but also clinical outcome of these patients undergoing a different type of ablative patterns.
Well, what are the differences in the surgery?
Well, the difference is that we have to deal daily in the daily practice with patients with enlarged atria. So we have a completely different electrophysiological substrate compared to patients undergoing catheter ablation. Therefore, we have to be more extensive, and the results of this paper address this topic. We have to absolutely treat also the right atria. Otherwise, we will face with the recurrences during the early and short-term follow-up.
Okay, so your study compared MACE procedure limited to the left atrium as compared to a more extensive procedure that included the right atrium as well. The results that you found, the more extensive procedure being superior, was it just that you were ablating more tissue, or do you think you were specifically addressing electrophysiological issues?
I think that if we look at the cardiac surgical population, we know that patients undergoing surgery because of mitral disease have also pulmonary hypertension, and therefore they have some sort of a right heart remodeling. This signifies that we have to face with enlarged right atria, and these enlarged right atria have multiple macro reentrant circuits. Therefore, if we do not address with reproducing the Cox-Maze-3 operation maybe with minimal invasive surgery or with different energy sources other than the cut and sew as suggested by Cox in the early 90s, just in this case we can treat also the macro reentrant circuits of the right atria. Otherwise we will incur, as I said before, in recurrences.
Well, what you say makes eminently good sense. We do have to recognize, however, that your study was retrospective and that the patients were not randomized in terms of whether or not they got the more extensive or the less extensive surgery. Did you do some propensity analysis to try to assess that?
Absolutely. You know that this can be a hot topic, and we can never have a definitive answer, which is better to analyze if a retrospective analysis may be in a registry, because this is the real world of our daily practice, or otherwise is it better to set up a multi-center randomized study. We prefer the first one, the registry analysis, because this reproduces our whole experience in the last years. Absolutely, we have to address those that are the biases of any kind of registry analysis. Therefore, it can be a selection biases from the surgeon at the day of surgery. Therefore, we also did propensity score analysis in order to avoid those that can be the major biases in terms of electrophysiological results. In particular, these patients were prospectively scored in terms of age, of years of AF duration, in terms of preoperative atrial dimensions, which are the three main determinants of recurrences in the majority of the papers published in the literature.
And so your propensity analysis continued to support the fact that the extensive surgery, in fact, was more effective. I think that's an important point, and hopefully cardiac surgeons around the world will profit by reading your paper. For Inside JACC, I'm Tony DeMaria.